Yeah.
And you can defend yourself.
I'll defend myself.
But then,
right?
was that a
Being
Okay,
messy.
Man,
I
hold
don't
on.
know.
Welcome to another episode of Messy Medicine. We are 4 board-certified physicians here to combat fake news with scientific and medical evidence. To my left, the lovely Dr. Barbara Joy Jones. To my right, Dr. Jocelyn Slaughter. And to my far right, my guy, Dr. Andrew Jimerson. And I'm Dr. Marc Jean-Gilles. All right, we're going to get serious. We still can have fun, but today's topic is it's a big thing, especially on social media. But I think that it also has a lot of misunderstandings, and that is maternal mortality. And when we talk about maternal mortality, the focus is on the disparity with Black maternal mortality. So let's just talk about what the definition is, so our audience is aware. Simply put, the maternal mortality rate is based on women who die during pregnant or up to 42 days after delivery. And to make it a truly maternal or obstetric related event, it has to be due to some obstetrical complication, meaning if a woman is pregnant and then she gets into a car accident, God forbid, and she passes away, that shouldn't count towards it, okay? So that's the definition. Let's get started.
Okay.
Any questions?
So first off, it is the big buzz on social media. So is this something that has been going on, or is it something that's just now coming to light? Like, what's going on with this? Has it always been, and now we're just keeping track? Like, what's up?
So let me get into this for a second. Women dying during childbirth is and around childbirth and due to childbirth related things is not new, okay? It is a natural cause of death. We talk about like what's natural and what's not natural. You know, dying during childbirth and surrounding childbirth is actually a natural cause. And in the history of, our world, death during childbirth was higher.
In
In
obstetrics.
obstetrics. Before medical interventions, women died during childbirth and after, and the majority of the deaths were attributed to hemorrhage, to blood loss. With medical interventions, that went down. With medicines and surgeries and all different things, that definitely went down. Over time, though, we started to see, is this starting to rise? With all the things that we were able to figure out with C-sections and Pitocin and vaginal laceration repair, antibiotics to help with infection because infection could cause death, even the physicality of the baby's body, coming through this birth canal. And then, of course, hypertensive things, preeclampsia. We were able to do all these things to help the majority of women not die during this process. But now we start to see it go up again. So this isn't anything new, but could the rise of this be new? So that was one of the things. And what was the interesting part it was a disparity between why was it more Black women who were dying from this natural cause than other races dying from this natural cause. And so I think that social media has, once again, unveiled things that are happening to Black people, like police brutality and everything else, that it's a disparity among Black people. And so that's the new thing.
I would agree that, social media has brought more attention to it, but, I started residency in 2005. I could tell you that, we've always looked at the disparity. A disparity is like why there's a difference between one group versus the other as far as outcomes go. So we've looked at it for a long time. We've tried to explain it. We've tried to implement ways to close the gap. So that part isn't new. As an OB, we've been aware of it for a long, long time. I think social media and influencers have brought it to the forefront. So, and I'm happy for it. It's a important topic to address.
So let me ask a question. So is it real or fake that there is a huge, significant disparity between the mortality rate for African American females versus non-African American females?
our two OB-GYNs.
Okay, so this
that
is
is
so this
real.
is real. Now, when we say huge, you know, there's statistics and there's we say numbers. There's a difference, and I say that unfortunately, Black people, no matter what anything is, it's, you know, if you look at neonatality, you know, death, almost every medical thing, Black people get the short end of the stick. And
We do worse.
And it doesn't stop with maternal mortality. So yes, with everything else, even maternal mortality, there is a higher number of Black women that die during childbirth and associated with childbirth than other races.
But let's put
Absolutely.
this in numbers.
real.
Don't you have the
Right.
numbers?
So
when we say a huge disparity, what does that mean?
So let's break down numbers, because I don't want women, Black women, being scared to get pregnant, because truthfully, the chances of you know, having a baby and living are very, very high. I mean, it's
Extremely high.
99.99%.
Extremely high.
So when we look at maternal mortality rate, we look at number of deaths per pregnant woman. We're looking at, for every 100,000 women, how many are dying. So overall, the newer studies now, after proper record keeping and review, it's now estimated to be like 10.4 out of 100,000 women during pregnancy will die. Now, white women, it's about 10 out of 100,000. When you get to Black women, it's now like 25 out of 100,000. So
That's why they say double.
so it's 2.5 times. There
Yeah.
are 2.5 more times likely to die during pregnancy or up to 42 days after. Okay, so, and that can include an abortion gone wrong. It can include an ectopic pregnancy. These are pregnancies, but they're early, right? But it still counts, all right?
So in clarity, out of 100,000 women, the average is about 10, but in Black women, it's
Right.
25 out of 100,000.
More or less, yes.
Okay.
That sounds pretty significant to me.
That is
So
significant.
let me ask you a question. Is there something inherently different, like from a biological standpoint, between Black women and white women that makes this difference like apparent?
So that's a very loaded question. So, you know, hold on, you being
Is
messy.
that a
Being
Okay, you
messy.
being
Well, 'cause
messy.
I'm kinda-
Okay, because
No,
now
it's all right. That's what we're here for.
That's
Go
what we're
ahead.
here for.
Go
Okay,
for
so
it.
when you say, if we say biologically, as far as the anatomy of a black woman and her vasculature and all, no. But as far as what the makeup and
Health status.
health status
Health
and
and socioeconomic.
socioeconomic, they sometimes are at a disadvantage. They can be at disadvantage with their nutrition, their starting hemoglobins. They can be at a higher level anemia. They can be at have more other medical problems
Right.
going on. So there is a health status issue, and then there is a access issue. They many times, and I say they because it's we, because I'm Black too, have lower rates of having prenatal care, having access to health care. They're sometimes not taking medications as they should. So there are reasons outside of a physician just not doing something right. But then I'm gonna say this other thing is that also and I think this is a medical thing, but when we look at treating patients and we're like, this is anemia, this is high blood pressure, a lot of the parameters that we use in medicine were based upon white male bodies. And so if you're judging of when you're making a call that somebody is hemodynamically unstable or whatever, a lot of our guidelines are not based upon Black women. So I think that it's so complex about why this group of people may have care that is not up to par. But I think that this is a marginalized group in many aspects. So I always say, I err on the side of the patient. You know, if I do my little part, if I know this group of people has a lot of, you know, that they have disadvantages, and we see it all the time on social media. I said I was having a headache. I said my blood pressure was up. I err on the side of them. They know their bodies better than I do. So as a physician, I try my best to listen and err to see what's going on with them versus what my textbook said they should be doing.
So can I ask another question?
Yes.
Okay, so okay, I just want to clarify. So you said there's biology, which is anatomy and the physiology.
Really, no, there's no difference.
No
that-
difference.
Then there's health status.
Yes,
And then you said access, which is basically health status.
yes.
So really there's only two. So it's like, so basically if you took an African American woman and a white woman and you, like they had access to the same care and stuff like that, do you think the mortality rate would be the same?
Well, hold on, but there's also
There's health.
There's
So-
That's what
also
I'm talking about,
bias.
health.
But hold on, so then okay, so now you have health status, but then there also is an element of bias. I do think that, as we know as doctors in medical
Conscious
school,
and subconscious
that there
bias.
is an element that the people who take care of people are human beings, and I think that there is an element of some bias with physicians and people. There is not a huge element, but I think there is an element where they're not believed when they say something, that some people, it's a cultural thing, could be a communication thing, and black women are looked at. We just had a reality person that that said some things about, oh, they're whiny and they're this and they're dramatic, black women are this, and so that some people hear that and their complaints and their symptoms may go unnoticed. And you hear it all the time. I told them I couldn't feel my baby move. I told them this. I told them that, and nobody listened to me. So I do think that there is an aspect that there are some physicians, nurses, people who treat black women wrong.
So you think there is some racial
Absolutely.
bias that causes increase in
Well,
maternal mortality?
so I'm a
In
disagree.
everything.
I would say, I'm
Small.
sure it's a small
It's
amount,
small,
right?
it's not everything.
I don't think that's everything.
No.
I think that, sure, is there a racist doctor out there somewhere that's like, I'm not trying to hear what this black woman's trying to say, or she's just full of it, or maybe, possibly, right?
I'm sure.
That probably could happen. There are nurses who may feel like, listen, I had one case, right? This patient, I knew this patient, she wasn't a complainer, right?
Because you knew her.
Right.
You knew her.
I knew her. The nurse, called me and was like, yeah, she's not contracting, but she's just complaining of pain, da-da-da. I just don't get it. She's 33 weeks, she's 3 centimeters, and, she has a fever, but it's just weird. It's just weird. And she just kept, brushing it off. And I'm like, she's complaining of pain, but we're not picking up contractions. And, I just said something was wrong, because, like Jocelyn said, I'm always going to err on the side of caution anyway. You complain to me, you're getting $1 million workup.
That's right.
So, I assessed the patient, and, I pushed on it, and I saw her white count. It was high. I got a CAT scan. Initially, they didn't see anything. I said, please look again. And then they said it could be the appendix. And but it could be. But then she was contracting, the baby wasn't doing good. So I said, we're delivering this baby. So, 33 weeks, delivered the baby. And sure enough, her appendix was ruptured, right? So
She could. Okay, now let's take that back. This is a scenario where okay, number one, was she black?
yeah, she was.
Okay, so this is
And it was a white nurse, yes.
okay. So this is a scenario where you have a patient that very well could have gotten sent home, who was having a ruptured appendix, and this is an obstetric patient with appendicitis is very difficult to diagnose.
It is.
Just to let everybody know.
It's not hard. I mean, it's
Because
not easy
it's
to
not
diagnose.
And to be clear, a ruptured appendix can kill you.
Yes.
Yes.
The appendix is, in a normal person, we kind of know where it is. But in a pregnant person, your belly's up, and so it kind of moves and it distorts. And so when we're trying to see where it is, it's in a weird place. And so the radiologist who was doing the CT scan, as Dr. Jean-Gilles said, was like, I'm not really sure, because the baby's moving in there, and
Right.
it's just all types of stuff. So,
But we're getting off topic,
Right.
Jocelyn. Sorry to cut you.
but you saved this woman's life because
Yeah.
you knew her and you
Right.
weren't dismissive of her complaints.
Right.
In a
But
very difficult situation.
with that said, all right, and I spoke to the nurse about it, and
What'd you say?
I said, look, you can't be, just downplaying stuff, all right?
So let me ask you a question.
Yeah.
So, because, I grew up in a medical family, and my dad, he's a physician, and when he was training, he noticed that there was a huge number of African American women that were getting hysterectomies that didn't need it. Okay, so they were just practicing on
Mm-hmm.
it, basically. Which, I don't know, I wasn't there, but I've seen stuff like that in
Right.
medicine.
All the time.
So when you say that, like, there's no, I mean, you said there was bias, but you were like, that
No,
doesn't
there-
really was contributing to,
Yeah.
and you can defend yourself.
I'll defend myself.
But then,
right?
You can defend
but
yourself.
like, I feel like the reason why we need more people of all different races and stuff in medicine, as well as gender and different sexual orientations, because you need people that understand their patients. So, like, do you feel like sometimes maybe you understand your patients, just maybe the little signals or cues or things that they say better than somebody else? It doesn't mean that they're, like, I'm not saying that the other people are racist. We might not understand some, like something that maybe an Asian person says, or
Right.
like, do you think that increasing the amount of representation in the specialty would
Absolutely.
decrease
There's
the
studies.
mortality
There's
rate?
there's studies that show that if like an Asian patient goes to an Asian doctor, a Hispanic patient goes to a Spanish-speaking doctor, a Black patient goes to a Black-speaking doctor in primary care, for example, there's studies that show that their outcomes are better, right? Because we know how to communicate, we know how to pick up those signals and those cues, right? So that part is true. That's important. But what I want to say is this. There is bias. There's no doubt about it, there's bias. I mean, we have our subconscious bias, like Joy says, whether we know it or not. Now, that does not explain every single instance. It doesn't even explain the majority of complications in regards to maternal mortality rate. There are some numbers that we have to address, right? In regards to Black women, it's multifaceted, right? One, how healthy are we, right? One, there's a lot more Black women with hypertensive disease, diabetes, being obese, and so forth. And these, there are more and more women overall getting pregnant with these comorbidities. And if they get pregnant with them, these can become worse during pregnancy. And that's where the risk goes up, right? Because the number one killers are, one, there's going to be bleeding, right? So, a woman can deliver and just continue to bleed, and, it can't be stopped. Then two, there's like hypertensive or cardiovascular diseases, right? That's severe high blood pressure, preeclampsia, cardiomyopathies. These are the top two killers, and infection, right? So we just are dealing with like a riskier population as is. But again, I wouldn't even say that's a part of it. That's not the main reason also, And I pointed out to Jocelyn backstage that, look, there are studies that show that if a partner is heavily involved during the woman's pregnancy, it goes across the board, Black, white, brown, doesn't matter, that the mother and the baby do better. So we can, look at various points and see where is it that Black women are
Are you
lacking.
saying that Black women don't have partners?
Well, that's part of it. Like if you're looking at stats, yeah, it's true. Like,
Is it because they're doing
You know what I mean?
the mom and the dad role, and they're too busy to get
right.
healthcare?
I would, yeah. I mean, this is my anecdotal experience, right? This is me dealing with family members, Black women who are family members, and seeing my patients on a day-to-day, and just knowing the numbers out there. Let's just talk about it, right? It's a problem, but 65% of Black kids in America are raised in a home with just one parent, okay? And if you just take that, right, and you have and I see them coming to my office. They're by themselves with their two kids, and they're pregnant, and they've made it to their prenatal visit by themselves. And then they go into labor, and they're not there with the father of the baby. It may be the mother, the sister, somebody, but it's not the father of the baby, right? It's not all the time, but it happens more often with Black women than other races, right? And so we have to address it. And it's like we Black women, it's true, they do have the least amount of support when you compare them to other women.
So this is getting real right now.
It's real. It's gonna like ruffle some feathers, but it's
This is gonna ruffle
true.
some feathers because I don't think that this is.
And I'm trying to like,
I know you're trying to
try
tiptoe
not to-
around it, but this
Yeah.
is probably. But I mean, if this is a huge part, is support. But the support you're talking about is support from the person that got them pregnant.
yes,
Is that the man
yes.
in their life is not the man
The
who got them
baby
pregnant,
daddy.
the baby daddy is not there supporting them, and that is one of many
Contributing factors.
contributing factors that nobody's talking about. Because it's funny, but I mean, have you ever heard this aspect of maternal mortality, black maternal mortality?
I have heard it like when in residency, when we're on inpatient service, that certain physicians and surgeons won't do certain procedures or interventional radiologists unless the person has a support person at home. If they don't have anybody in support roles, the procedure is futile and they don't do it. So I would say the same thing because C-sections are real surgery. Having a baby is a real health thing that a lot of times if you don't have anybody who's support at home, it shouldn't be done.
So maybe one of the aspects of this black maternal mortality should be the black men stepping up and saying, we've got to support our women when they're pregnant.
That's absolutely.
That we have to be there at these appointments, at these deliveries, because one aspect, not all of it, and that's what I always say, do what you can control. Whatever you can do what you can. As a physician,
Absolutely.
I can't make a baby daddy come, but I know I can listen to you and I can try to err on the side of caution as, you know, everybody do what they can to help support these moms.
I'll make it simple. When regards to the disparity between black women and other races, right? It's not just one thing, but it's a little bit of everything, right? So, yeah, part of it is, you know, there are probably more cases of diabetes, high blood pressure, and medical comorbidities among black women. That's not all of it, but that's part of it. Part of it is they're doing it by themselves. That's not all of it. That's part of it. Part of it could be that, yeah, there are some, you know, implicit biases. You could put systemic racism in there. That's part of it. That's not all of it. But it's just, you know, cumulative effect is just, this is what you see. Black women are 2.5 times more likely to die during pregnancy than their white and Latino counterparts.
From a primary care perspective, there's this new word that's coming through called weathering. And what that means since 80% of my demographic that I see is black women and women of color, there's this micro and macro trauma that they deal with in the workplace or just out and about that actually causes stress. And in my opinion, 70% of what I see come through the door is unmitigated stress that then turns into obesity, hypertension, high cholesterol, diabetes, and all those things. And somebody who is Caucasian may not have to deal with that weathering of always having to be vigilant and aware of these micro and macro traumas that happen all day and every day, and it kind of weathers like a rock where you have like a river and all of a sudden the rock that used to be this, it's weathered and now it's a small pebble. That is what's happening with black women. And at the inception where the baby is conceived, the health of the mother is much lower. Then you go into the health system and your pain is marginalized, that they think a woman's pain should not be taken seriously, that when you actually complain, it's this angry black woman versus being assertive and sticking up for yourself, or that you're actually having pain. Why does this pain matter more than this one? And even still to this day, it's not maternal mortality, but I had a woman who cut her finger deeply, and they didn't anesthetize her before they started stitching. And this is a black woman in 2023. And so why? If it was a Caucasian woman, would have gotten anesthetized first? Would they have given her lidocaine? This is still happening. Her pain wasn't taken seriously, and that's likely what's happening in the maternity wards.
Well, I heard, like, I guess it was a rumor, or I don't know. They used to say that black people had a higher pain tolerance, you know, and so they would like not give us pain medicine until a certain level of pain. And I think there's still some rumors about that. Like, I was talking in the OR to one of the CRNAs, And they brought that up, and I was like, wow, that's still like a myth that's happening, that we have thicker skin and that our pain tolerance is higher.
I mean, you know, I don't know about the pain, but I can say that black women do take on a lot more statistically. And this is not me just saying it. I mean, if there are more black women raising kids by themselves, handling the finances by themselves, raising their kids by themselves, they are taking on more than, say, a white woman or a Latino woman, right? And you know, part of that can make them tough. It can make them, you know, also fragile at the same time. So again, it's multifaceted, right? It's complicated. But with that said, the maternal mortality rate has dropped. So it's not like doctors are out there. I would say the majority of doctors want to see
give us the real, because everybody thinks that it's going up, but can you tell us the trajectory and what's been going on?
From 2008 to now, to 2021, the maternal mortality rate has decreased, okay? So we have seen significant improvements, especially with preventable things that related to preeclampsia, bleeding, and so forth. So the things that are known as the primary killers in regards to maternal mortality rate, medicine and you know, treatment modalities have improved to decrease you know, these bad outcomes. But you know, I've seen people on social media saying, "Oh, we want it so that no woman ever dies." I don't know if we'll ever reach that point, but that's the goal. We always try. We try our best, and you know, it's not always going to be perfect. Nothing is, but that's the goal.
What's the definition of prenatal care? Like, what does it entail? Why is it important? And do you think that the lack of prenatal care, getting prenatal care, affects mortality rate? And do you just see it in African American versus Caucasian women, or do you see it like in rural versus urban areas?
Well, prenatal care, we would consider that in America is where you have an established obstetrician that could be, and it's associated with a physician that is going to care for you for your pregnancy. Most people establish it in the first trimester of pregnancy, which is somewhere before 12 weeks. And that physician has agreed to care for you for your entire pregnancy. So you know that they're going to see you once a month, to however often that the American College of OB-GYNs tell you should be seen. And then also they're going to deliver your baby at the hospital that they have credentials at, and you're going to get care after pregnancy. So it's basically prenatal care. Somebody is agreeing to care for you. Some person is agreeing to care for you. It's a contract that they have together. This is so important because if you don't have that, you're kind of just out in the wind. You're kind of just winging it on your own. You don't have a home to go to. You don't have somebody that's checking on you and the baby. And so you're just kind of out there. So if you don't, you're nobody's there to catch problems, to deliver your baby early, to prevent. The biggest thing we want to prevent is death and stillbirth of the baby. Death of the mom and stillbirth of the baby. So if you don't have that, then you're at risk for having those things. And so if we don't, or small baby or anything happening. So if you don't have prenatal care, you're at a higher risk of stillbirth of your baby, problems with your baby, or death of yourself.
I'm seeing on social media a lot of people with this whole Black maternal mortality thing. People are thinking that it's safer to deliver babies at home. What is your thought process on this TikTok, Instagram thing that says, "Hey, you're better to deliver your baby at home than a hospital because."
Right. Well,
what's your thought?
Well, I'm gonna say this is it's not illegal to have a baby at home. It's not illegal. Many people don't even make it to the hospital. It's not illegal to have a baby at home, but we are board certified physicians and we abide by the American College of Obstetrics and Gynecology, and home births are not recommended by the American College of Obstetrics and Gynecology. It's recommended to have your baby in a hospital. Safer for you and safer for the baby. If the baby needs resuscitation, if you need help with blood loss, all those things is safer to do in the hospital. But it is not illegal to have your baby at your house. So we would not recommend that as a safe thing to do, although it is a thing that has been done. But if we look at the historical data of home births historically, they had a much higher rate of maternal mortality and morbidity than anything that's happening right now.
So you think, how can the mortality rate be going down if the trend is for people to have their
baby at home?
Baby at home.
Not too many people are
People
having
are not
their
doing
babies
it.
at home. So
They just
Just the
talking about it.
influencers.
They just talking about
Right.
it.
But
It's just a talk.
I would just say that, we can attest to it. There are so many things that just can go wrong, right? And we, thank God, most of the time, everything goes smoothly. But there's things that can go wrong beyond our control.
Natural.
And I'll give you an example. I had a patient, she delivered, and, her uterus it needs to clamp down. It needs to get tight to stop bleeding. She just kept bleeding, right? Well, luckily there's blood products and things I can give to try and stop the bleeding. And I mean, she's losing blood fast, but we're giving it back to her. Ultimately, I had to take her to the OR and take out her uterus because she just wouldn't stop bleeding. If she was home, she would have died, right? So,
Which is a natural cause of death.
right. It's preventable though. It's
Yes.
preventable. So, for me, knowing what can go wrong, I would never encourage a home delivery. Matter of fact, I think here in the state of Georgia, most home deliveries, it's usually a lay midwife that does it, not a certified
You
midwife.
you cannot keep your nursing
Right.
license
So no,
and do a home birth.
I would not. Yeah, I would never.
I didn't even
recommend
know that was a thing, a lay midwife versus a.
Yeah.
It's just somebody who says they deliver babies, but they didn't go through the proper training.
Yeah.
And the insurance is not going to cover it. So you have these.
Anybody could have a baby at home.
Yeah.
It's not illegal.
I've seen people have babies.
Oh, yeah. In the
In the
parking
car.
lot. Yeah.
It's
parking
nothing
lot.
illegal. It's a natural process. But
So if we're gonna be assertive about decreasing this, I would say so Dr. Jocelyn Slaughter-Moore delivered my babies. I had 2 back in 2023. And so you asked me a question backstage, and what did you ask me?
I said, at any time during your pregnancy or birth, were you scared of dying?
The answer is no, because I had you. Now, if you weren't present, then yes, there were different parts that, because I did have preeclampsia. So I was pregnant with IVF twins, and they had to be born at 34 weeks. My little girl was only 3 pounds, so she was small for gestational age. So you were saying that she only had a 5% chance of making it if I delivered vaginally. I lost 2 liters blood during the C-section, so I needed a blood transfusion. So there were, and I actually had postpartum preeclampsia, so I needed magnesium sulfate and I needed to be knocked out for 24 hours. If it wasn't for you, someone who looked like me, somebody I knew had my best interests at hand, I would have been scared, but it's only because of you that I wasn't.
And that's what I said. I said, I know that you've known me for a long time and we're friends. But I said, but I feel like all my patients feel that way.
That's
that
just
they
so sweet.
that they trust me and that they know that they're not worried about dying because they have the trust, and you have to have the trust with your doctor. I had my last birth was also traumatic.
He saved your life.
And he
I
actually
wouldn't go there.
came in the operating room while I was bleeding.
So she was
Sitting next to
bleeding
a bunch
out.
of lifesavers.
And he helped to make sure I didn't bleed to death, And I remember hearing his voice and then saying, "You're bleeding too much, I'm coming in." And I was like, okay. And I never was worried about dying, because I knew the people who were around me. I wasn't scared.
I would just say, like, she had a wonderful OB-GYN.
Yes.
She asked me to just take a look, ask what I think, and I went in there and just.
Right.
It was
and
a team
also,
effort.
Team
my
effort, yes.
OB-GYN, I never was worried about dying. Like, I was just, y'all got me. But that's the relationship that patients should have with their doctors, no matter what color they are. That they should feel that you got me. And if you don't feel that way, then you need to get another doctor. If you don't feel that your doctor's got you and you feel that they might not have your best interest at heart, or maybe they're not listening to you when you're talking, they're talking over you, then that's not the situation you should be in. And if most of us live in a place where there's multiple physicians, so that's the part that the patient should try to do. We as physicians should listen more to our patients. Men should be more assertive in being a part of their women's lives. And as society, we need to protect our women as best as we can.
I have a messy question.
Yes.
So you guys know that basically, like we talked about, the hysterectomy, the unnecessary hysterectomies that were done back in the 70s, 80s. Do you think there's any unnecessary or excessive surgeries or procedures that are being done during childbirth that might contribute to this mortality rate?
Yes, the C-section. So, the C-section is a bloody surgery, okay? You're cutting right through the uterus. It's going to bleed. So, anytime you do something where there's going to be more blood loss, you're just increasing the risk of so much blood loss in one patient that they die, right? So yes, but again,
So do you find that there are more C-sections performed on African American women than other women? I don't know if that statistics is out there. And if so, are they practicing the C-section, or
So,
is
hold
it
on.
higher reimbursement?
No.
Damn,
I don't,
hold on.
no, I don't subscribe
no, we don't
to all
get
of
reimbursed
that.
more money.
So I don't
but yes.
subscribe to. So I think that that's a loaded question. I know Mark's saying that,
I said it was messy.
Right. Can we, as OB-GYNs, I think most of us don't want to do C-sections on patients.
Right.
We try our best not to do C-sections on patients. It takes us longer. We don't want to do a C-section. We only do it if we need to do it. That's our goal, is to do a C-section only if needed. Lots of doctors and departmental chairs and things we have checks and balances to make sure that doctors are only performing this when it's actually necessary. I'm a department chair, and I sit on different committees, so we have checks and balances so that doctors are just not running wild saying I only do C-sections. But there are other countries, like in South America, where they do a large amount of C-sections. That's
all my
all they do.
Colombian, Venezuelan.
And how is their mortality rate?
It's pretty wonderful, and they don't have because they don't want anything coming out of their vagina. They want their vaginas to be intact. So from what we understand, it's not a huge problem. But I think that we do want to save the C-section in America for a need where you're trying to protect the baby or you're trying to protect the mom.
So again, I go back to the C-section rate. That is something that the American Congress of Obstetrics and Gynecology and OB-GYNs overall, we always look to lower that rate.
Want to lower it.
Okay, so
Safely, though.
yeah,
Not at the expense of the baby.
We do it when needed. Right now, the rate is, I think last I checked, was 33% across the board. We'd like to see that lowered. Okay, and again, it's simply because if you compare it to a vaginal delivery, there's less blood loss, and the thing that can kill women, we talked about it, is blood loss. So logically, you decrease blood loss, you decrease the risk of death. Now, when I say it's overdone, it's a dirty little secret for people out there. Listen, doctors are humans, and I have seen doctors fatigued, and they can't wait for this patient to deliver or progress, and or they just get super duper scared at one little heart rate drop, and they don't want to get sued. So the quickest thing is, let's just do the C-section. It'll be over with, or I'm not going to get sued over this little baby's heart rate dropping. So it does get overdone, right? We know that, and it's something we're always working on to improve. So I would say that's one surgery that's overdone. I don't have the numbers on race, but it's possible. Again, going back to that implicit bias there, it is possible. I don't doubt that somewhere out there in a rural area, there's a white doctor who may not want to deal with a black patient that day. It's possible. So he's like, all right, you know what, let's just do the C-section and get it over with, right? That is a possibility. But again, that's not the only contributing factor. I want to put that
Well,
there.
because we're kind of, it's like we're in Atlanta. So we don't really know, we're in this sort of city where there's a lot of
OBs,
a lot of African American doctors and a lot of African American patients. But what do you guys think, like, in these, I call them square states, like Montana, Utah,
Wyoming.
where we're not concentrated? I mean,
I would say it depends. The patient population is going to be more homogenous, and if you're just dealing with
No, but I'm saying if you're an ethnic person that's out there and you're a non-white person, like,
I think you
they're getting the same type of care?
I think most likely they are, and they're probably getting the same outcome.
Most of us went to school with. I went to University of Chicago for medical school, and I feel like the majority of physicians, I don't know about you all, I feel like are not biased. I think the majority of physicians are not biased, and the majority do try their best to provide care for everybody. So, I don't think that you're only going to have a good experience if you are with a black doctor. I just think you just have to be comfortable with your doctor. And I think that as long as you have a relationship and you feel comfortable with that person, But I mean, the black doctors only make up what, 2%?
2%?
2% of all physicians. There's no way in Atlanta you might have a black doctor, but it's very difficult in America to have a black doctor or a doctor that matches your ethnicity. It's extremely hard. So I do think that overall doctors, you know, we encounter medical students all day, all the time of different ethnicities that are really caring people, and I think that there's so many courses in medical school to stop natural biases. So I think that the overall care is improving, as we see with statistics, that it is improving, but I think we have to remember where we came from, never forget it, and to always constantly be checking our own biases to say, wait a minute, am I doing something? Let me make sure that I'm giving this black person the right medicine because I could be falling into a bias.
To our fellow colleagues out there, again, fellow OB-GYNs that is, obviously, don't be hesitant to do a complete workup. You know, take every complaint super serious, and I think the workup will lead you to a diagnosis along the way. And for all our patients out there, go see your doctors, make it to your appointments, and let your voices be heard. If you have a headache, you emphasize, look, my head is pounding, that'll grab the doctor's attention. Don't hold it in. If you have chest pain, shortness of breath, I get these complaints all the time. I tell my patients, there's no crying wolf over here. We will work you up. You make sure that you're heard and advocate for yourself. And to all the men out there, if you want your lady and your child to do better, you need to be there. It's just that simple.
Amen.
And we will close on that note. That's our episode. Thank you for another episode, watching us for another episode of Messy Medicine. That's our time for today. Had a great time with y'all, and if you enjoyed what you see, subscribe to the channel, comment below. Till next time.